All right, here is another wonderful lecture about tone abnormalities. Here is our outline for the day, and here are some key terms that we're going to cover. So muscle tone, the definition of that is underlying tension in the muscle that serves as a background for contraction. Some of the challenges to assessing muscle tone is that the patient must be relaxed if they are actively resisting the muscle stretch, or if they're even trying to help you out. It's really hard to assess and get an accurate idea of their muscle tone. And then changes with movement, posture, and tension and environment can all affect your assessment of their muscle tone. Hypotonicity or low muscle tone is a decreased resistance to stretch. So you can be so low that you have flaccidity, which is a total absence of muscle tone. This sweet little baby up here, I would say, is definitely hypotonic, but maybe even flaccid, or he's just limp like that. Some of the common diagnoses that you see hypotonicity or low tone are Down syndrome, some of your other syndromes like fetal alcohol syndrome, or a lot of the pediatric diagnoses like even autism. Some of those are all associated with low tone. Hypertonicity or high tone, an increased resistance to stretch, is the opposite. And so some of the words that are associated with hypertonicity is rigidity. So that is a resistance to stretch regardless of the velocity. So whether you move the muscle through the range slowly or fast, it resists it regardless. It's tight the whole way. With spasticity, that resists a stretch at a higher velocity. So when you move it quickly, it jerks back against it. And with clonus, this is a rhythmic oscillation or beats of involuntary contraction in response to a quick stretch. So typically the way that we test for clonus is we quickly dorsiflex the foot. So this would be my foot. Here's my ankle and my leg. We quickly dorsiflex. And if they have 2 to 3 beats, like you push it and you feel 1, 2, 3, that's normal. So 2 to 3 beats of clonus is normal. Most people have that. But if you push and it just shakes or does like 5 or 6 beats before it stops, that is considered clonus, and that is a sign that there has been some CNS damage. So some of the common diagnoses that you see clonus in are stroke, cerebral palsy, brain injury, things like that. Some things to be confused with tone is a voluntary muscle contraction. If somebody is contracting, then you can't really get a good idea of their tone. Posture, just because they have poor posture or tightness somewhere or weakness somewhere, it doesn't necessarily mean that their muscle tone itself is high or low. Just because somebody has worked out a lot and built their muscles up doesn't necessarily mean they have hypertonicity. They may just have strong muscles because they worked them out. Some of the disorders that cause fluctuating abnormal tone or abnormal movements that are involuntary, such as dyskinesias. Those are abnormal involuntary movements. Some of those are chorea, bulismus, tremors, and athetosis. So I have some YouTube videos I will put in here for you to watch so that you can kind of see what each of those look like. Yep. Okay, quantitative measurements. So things that give you a number to help you quantitatively measure the muscle tone would be a dynamometer, an isokinetic testing system, an electromyography, a pendulum test, which I have a video to show you that. And these can measure different types of strength and give you a more reliable measurement than just describing the quality. Some of the qualitative measurements are scales, stretch reflex test, the Ashworth and the modified Ashworth scales, which I have a YouTube video I'll put in here for you to watch with that as well. Some considerations. When you are checking somebody's muscle tone, you want to pay attention to what position their body is in. So if you remember, your head position can elicit some infantile reflexes. So if you turn an infant's head to the right, if they're at a certain stage, then they will do this ATNR reflex. Or if you extend their head, then they might extend their arms with the STNR. If you flex their head, they may flex. All of those can change how their muscle tone feels. So if you are checking the muscle tone of somebody who has reflexes that have not integrated, meaning they did not disappear at the age where they were supposed to, or maybe it's a baby you're testing that still has the reflex they're supposed to have, or maybe it is someone who's had a stroke or a brain injury or something like that that has caused those reflexes to return. That's a common thing with certain types of injury to the central nervous system. Some of those reflexes will resurface and cause them issues again. And so if you have somebody that you may or may not know still has some of these reflexive patterns, and you have their head propped up on a bunch of pillows and you're trying to get elbow flexion and they're stuck in extension, you're not going to get an accurate rating of their tone. So ideally, you keep their head in a neutral position, their head and trunk in neutral alignment while you're testing the movement of the extremities to avoid these reflexes. Some of the other considerations, you want to standardize your touch. So you want your hands and any instruments you're using to have a consistent temperature. Try not to use, freezing cold hands. That would be oftentimes something that might cause a muscle contraction just reflexively. Give them more cues and warnings that you're about to touch them, or tell them, describe what you're about to do. Keep your hand placement consistent. Sorry. To get consistent and reliable measures. So even the way that you touch a patient matters. So if you touch with like a wide spread out hand, typically that's more inhibitory or relaxing to a patient. If you touch with a very narrow grip, or even just one finger, just kind of poking, or quick touches, or out of nowhere and they're not expecting it, all of that can actually elicit a muscle response, a motor response where they tighten up. Consider muscle strength when you're testing so that you're not placing the same amount of resistance on a quadricep and on forearm muscles that are much weaker than the quadriceps. So pay attention. Always apply your resistance or your movement or whatever you're applying slowly and gradually. You don't just crank on somebody quickly because you could injure them, and you can definitely elicit a reflexive tightening of their muscles. Muscle tone is most accurately measured in mid-range. So what I typically have people do is start with an elongated position, have them go as short as they can, so through the full range, and then I take them somewhere in the middle before I test either their tone or their resistance, like do a manual muscle test or anything like that. Muscular contribution. So in the contractile element, things that contribute to a muscle contraction are the myofilaments. That's the part that shortens and lengthens. And cellular elements, including the neural stimulation of calcium to be released, the formation of the actin and myosin protein cross bridges, ATP energy that's being used to form a muscle contraction. These cross bridges are formed at mid-range of the muscle. The most cross bridges are formed, which is also why mid-range is where someone's the strongest and the best place to test them. There's a length-tension relationship. So you want, as somebody works out and shortens a muscle, you want them to stretch it to maintain that length-tension relationship so their muscles able to go through the full range. It can generate more power that way. It can also prevent injury because the more tight a muscle is, the more pressure it's putting on the joints, and it can help the muscle generate more force. So I tried to find a picture of somebody being muscle tested in mid-range, and yeah, I had trouble. So this is what I ended up with. I was trying to get somebody flexing mid-range. So he's got his elbow like halfway bent while he's flexing. But just as a reminder that mid-range is where we are the strongest. All right, neural conditions. So neural input from the periphery, from the spinal cord, and from the brain all affect your muscle tone. The alpha motor neuron is the final common pathway that directly stimulates muscle contractions, and it's responsible for generation, summation, and conduction of an activating nerve signal. So generation is creating a muscle contraction. Summation is adding the myofilaments together. So you are bringing in, like recruiting more and more fibers to create a bigger contraction. Conduction is that nerve impulse being passed along so that a contraction can occur. Here is the structure and the function of the nerve cell. So over here is a dendrite at the end, this colorful part, and they receive the messages. And then the long skinny part is the axon that conducts the messages with the action potential. And then at the end, the synapse is where neurotransmitters are used to transmit signals to the next nerve cell. So dendrites receive the messages, axons pass on the messages, and then they're pushed out through the synapse to the next nerve cell. Here is action potential. Remember, this is what causes a muscle contraction. So first there's depolarization and repolarization. These processes are initiated by the sodium-potassium pumps that alter the charge of the neuron. It creates a wave of activity along an axon to create a nerve impulse and a muscle contraction. So these are key players in muscle contractions, and that's one reason why you have to replenish electrolytes after a big workout, like a long run or anything like that, to restore these so that you can maintain good muscle contractions. So the charge of the cell is changed by these sodium-potassium pumps that move these particles around to make areas more or less negatively charged, and then that creates the environment needed for a nerve impulse to be passed on and to stimulate a muscle contraction. Saltatory conduction, so this is just referring to the movement of impulses down the axon by jumping from node of Ranvier to another node of Ranvier through the myelin. So the myelin insulates the axon to keep the nerve signal from being dispersed and from being diminished as it travels, so it can stay strong and so it can travel quickly. So it actually is able, rather than moving along the whole line of the axon, it's able to jump from place to place because of these Schwann cells, which is the myelin that wraps around the axons. And actually that's what makes white matter in the brain and spinal cord is the myelin. It's a lighter color, and that is what helps transmit the nerve impulses. Some of the sources of neural stimulation of muscles. So the peripheral inputs include muscle spindles, Golgi tendon organs, and cutaneous nerve receptors. So cutaneous receptors are receptors in the skin that identify and that just transmit. They don't identify. They transmit signals to help with stimulating muscle contractions. The muscle spindle, it is a stretch receptor, so it is coiled around the muscle itself, and as the muscle changes in length or changes the speed of movement, it relays those information. So here I have receives and conveys, but it sends those signals along from the periphery to let your brain know what's going on and where your body is in space. So the muscle spindles convey the information about muscle length and speed of movement back to the spinal cord and back up to the brain. The Golgi tendon organ, this is a sensory organ. Remember, the tendon is where the muscle attaches to the bone. and it monitors changes in the muscle tendon unit, so it's sensitive even to slight changes. The information is transmitted at the level of the spinal cord, and it has a protective mechanism. So the Golgi tendon organ can send messages into the spinal cord, and they can go up to the brain and be interpreted, or it can, in most cases, it can, if needed, go to the spinal cord and straight back out through a motor neuron to cause a movement. So if you were to be pulled really hard in one direction, you don't have to consciously think, oh no, this could hurt me. I should pull back and protect myself. This response, this reflex arc already does it for you. So the input comes in, oh, we're moving too fast and too quickly, too hard, too much, whatever it says, and it goes right around the spinal cord without traveling up to the brain and quickly sends an impulse right back to reflexively tighten that muscle to pull against that force. There's a similar reflex arc to pain. So like if you put your hand on a hot stove, oftentimes you reflexively pull it off before you even consciously notice that it was hot. And that is also a similar reflex arc where that temperature sets off an alarm. This is dangerous. It's regulated at the spinal cord rather than going up to the brain and happen to be interpreted. So it's much quicker, and it immediately causes a reflexive motor response to keep you from getting injured. The stretch reflex is also a component of the Golgi tendon organ, so it's kind of the same thing as it's the reason why we don't stretch patients quickly. We don't put them through range of motion in a fast speed, because when you do, the Golgi tendon organ sends a signal to the spinal cord and that muscle tightens up. So we want to stretch patients slowly to avoid eliciting a stretch reflex that will cause them to tense up and resist that stretch. So the Golgi tendon organ, it reacts to extreme stretch, significant tension, or high-speed movements in order to protect the muscle from tearing. And this input goes to the spinal cord, is relayed back to the muscle to cause a quick response in order to protect you from injury. So what I kind of just described in the last slide. Autogenic inhibition is somewhat the opposite of that. So once you maintain a lengthened position for long term, so really more than 30 seconds is what kind of the research says, the Golgi tendon organs then send a signal to the spinal cord to relax and inhibit the muscle tone. So this is why we have people hold stretches for longer than 30 seconds, because if you maintain a position for a longer duration, the Golgi tendon organ's like, hey, calm down, muscles. We don't have to be on high alert. We can relax. We can sit down for a little while. And because it's no longer trying to protect you by tightening up. So then it allows your muscle to reach a longer length by relaxing. This is one of the reasons we do a low load prolonged stretch, and that is most effective because of this autogenic inhibition and because of what you learn in your next lecture about collagen being able to be reorganized and redistributed and water redistributed and all that to maintain the gained length. There are also spinal inputs that tell your brain that you are in pain. There's reflexes, there's automatic responses, we've covered that. There are supraspinal inputs, so these are from the brain, they're more complex, they cause more intentional movements, more awareness, and some of these areas that are responsible for that are sensory motor cortex, the cerebellum, the basal ganglia, and the limbic system. If someone has low muscle tone, the consequences are there's insufficient motor unit activation to prepare for holding or moving an object. So like you go to move a box and you're like, yeah, I'm not strong enough for this. And that's because there's insufficient motor unit activation. So your motor units are not all joining in like they could if maybe you have worked on strengthening a little bit more. Poor posture is a side effect of low muscle tone. Difficulty with certain movements is a side effect. one of the things that often leads to low muscle tone could be immobilization. So if you are immobilized for even a week or longer, you start to lose muscle tone. So if you have a cast on for 6 weeks, imagine the amount of muscle tone you lose. Not only tone, but strength. And there are actual physiological changes occurring in the muscle where sarcomeres are reabsorbed and the muscles actually kind of eat themselves in ways. And so there's actually less components of muscle to even work with once you come out of that immobilization phase in order to re-strengthen. So that's one of the reasons a lot of doctors went from, here's a cast and now you're in it for however long, to more so here is a brace and let's do it as short term as we can while still allowing the bone to heal completely, so that you're not immobilized as long as you don't lose as much muscle tone. For modalities and using modalities to increase muscle tone for someone with low muscle tone, so electrical stimulation, hydrotherapy, quick ice, they can all be used in conjunction with therapeutic exercises, orthotics, functional training. So again, you don't do just the modalities and expect to get stronger. You may, in some cases, be able to maintain some muscle strength or tone through just modalities, like if somebody is immobilized for a while, but you're not going to gain strength. You may just be able to maintain some of what you have. When we contract a muscle and send nerve impulses from within, those nerve impulses cause the smallest muscle fibers to be activated first, and then the larger, and then the largest to summate and create a larger muscle contraction. When we stimulate nerves and muscle contractions externally, like through a TENS unit, really it's not TENS because it's neuromuscular e-stim, but through an electrical stimulation unit, they actually stimulate the biggest fibers first and then on down to the smallest and smallest. So one reason, if you've ever seen Russian stim be done or any type of neuromuscular e-stim, we have the patient do an active muscle contraction while the machine is contracting. It's kind of to get a full contraction. So the patient is actively contraction. It's getting the smaller vessels all the way up to the bigger, and the unit is getting the bigger contraction down to the smaller. So it creates a full loop to create a full muscle contraction. So it works much better with active muscle contraction, and all of the physical agents are going to be much better and effective when they're partnered with other treatments like therapeutic exercise than when they're used by themselves. When you have high muscle tone, some of so abnormally high excitatory input to an intact motor neuron, that's what causes high muscle tone, one of the causes. It can cause muscle spasms. It can cause contracture. So this top picture is a contracture, and it's also in kind of a stereotypical movement pattern. So like, let's say somebody had a stroke, there is a synergistic typical movement pattern that you see after somebody has a stroke that draws them into a synergistic movement that's typical for that condition. And it is because of high muscle tone or spasticity, because nerve impulses are randomly being sent for that muscle to contract, even though you're not consciously telling it to. Abnormal postures can lead to skin ulcers, difficulty with ADLs, dressing, transfers, hygiene. So one example of that is like somebody who sits in a wheelchair all the time. If they're not getting stretched often, then where their legs are stuck together all the time and not being stretched out, so they're adducted and not being abducted, they can develop a adductor contracture that causes it to be really hard if you need to help them change clothes or change a diaper, like wiping that area. You really need to be able to spread the legs out to access that area for cleaning, and it's very difficult if they are sitting in that position all day and not being stretched out of it. So those are some of the consequences of high muscle tone, increased muscle tone. the way that physical agents or modalities can help with people who have increased muscle tone. So the book recommends prolonged icing before stretching, which is a very interesting recommendation to me because I always learn do not stretch a cold muscle, and that's still the rule that I follow. So I might use heat to warm up the muscle before I stretch, but I personally don't use ice. But evidently there has been some success to using ice to kind of calm down the tissues before you stretch. I would just be very careful and cautious so that you don't cause an injury. Continuous passive motion. So this machine in the picture at the bottom is one that you can put someone's arm or leg or body part in and set it to parameters like bend this much and extend this much, and it continuously in a slow movement goes through that full movement. So it just slowly takes them through the range that you have set. So it's safe after a surgery typically because they're not going outside of the parameters that the surgeon set, and yet it continues to move them in a safe way where they're able to keep from getting scar tissue and limited motion, and it helps with the swelling and everything else so that they can maintain some of that motion. Biofeedback can be an adjunct to some of the range of motion exercises, prolonged stretch, positioning, orthotics, task training, medication, surgery. All of these things can help with high tone. So one of the types of medication that I've seen used for increased tone, so two of them are Botox and baclofen. So Botox is an injection that they place in the area of high muscle tone, so typically in an area where they have spasticity. It could even be rigidity, but they then, the Botox then relaxes that muscle and allows for more movement, more function. If that seems to help a lot, sometimes they will implant a baclofen pump that has a similar type of medication in it that is released, not continuously, but consistently over time to give them basically little shots of that medication without them having to come to the office every week or every so often, so that it constantly gives that medication needed to decrease the tone. And people I have worked with that have a baclofen pump will often be very noticeable when their baclofen is low and they need to go back to the doctor and get more baclofen. Sometimes if, let's say they just came from the doctor, it's been a week or so, and you know the baclofen's not low, but suddenly they're tight again, I would send them back to the doctor because maybe their baclofen pump is stopped up, like it's not working correctly, or maybe something else is going on. But it does seem to help a lot with significant muscle tone. There was one more. Okay, I think it must be on a different slide or a different lecture, but I want to make sure that I've said it because I've already recorded these lectures 3 times today, really 2 for 2 of them and 3 for 1, because I keep messing up on them. But I do want to say that contractures don't respond real well to treatment. So like it takes a lot to reverse the effects of a contracture because some of those sarcomeres are absorbed, so the muscle is shortened and really has trouble getting to that normal length. And so the best thing to do is avoid contractures versus trying to counteract the effects of contractures once they've happened. All right, so that's it for that lecture for today, and I will see you in the next lecture.